My name is Morgan Duke, and I'm a nurse practitioner student at Auburn University. Today we are going to be learning about hearing loss in the geriatric population. We're going to be focusing on age-related hearing loss, or presbycusis, which affects 1 in every 3 adults over the age of 65. So very common, and it's important that providers understand this and learn how to diagnose and treat it. So there are 2 types of hearing loss. You have sensory neural and conductive. Presbycusis is the most common type of sensory neural hearing loss. It affects both ears and is caused by the natural aging of the auditory system. So unfortunately, these changes are permanent, and they can be due to structural, neurological, or even circulatory changes involving the ears. The hearing loss occurs gradually over time, and it can affect the patient's ability to hear higher frequency or higher pitched sounds. The patient may complain that they can hear someone talking, but the talker sound like they're mumbling, or they're slurring their words. The patient's also going to have a harder time hearing in areas where there's a lot of background noise. So there are some physiological factors that also contribute other than age, such as patients who've had prolonged exposure to loud noises like military personnel or factory workers, patients with underlying health conditions like diabetes, heart disease, poor circulation, even smoking and family history of hearing loss play a role. And then you've got drugs such as Lasix, antibiotics like gentamicin, chemotherapies like cisplatin, and even certain NSAIDs that are known to be ototoxic and can cause hearing loss. So it's important to recognize those. Diagnosing presbycusis it depends on the patient's symptoms as well as your physical exam. So the patient may complain of others' speech sounding muffled or slurred. They may have ringing in their ears. They may report difficulty understanding words with the S or the TH sound, and they may complain that some noises are just overly loud or annoying. So one, it's very important to ask the patient first to rule out if they've had any ear pain, fever, drainage, problems with earwax in order to rule out an infectious process or conductive hearing loss. Second, it's important to ask the patient if they've had any trouble hearing the phone ring or the microwave beep, or if they've had trouble hearing, engaging in conversation where there's background noise. Ask the patient about their occupational history to determine if prolonged exposure to loud noises has played a role. And then also you want to review the patient's health history and current medication list to determine if hearing loss could be related to a medical condition or a medication. So on exam, you may notice that your patient asks you to repeat yourself, talk louder, or you may even look disengaged or confused. They may even turn to their family and say, "What'd she say?" So those are some physical signs. On your otoscopic exam, you're going to want to rule out inflammation, infection, drainage, damage to the eardrum, or a blockage from like a foreign object or earwax. So a third way to detect hearing loss and determine what type of hearing loss are the Weber and Rene tests. So on the Weber test, normal hearing is going to produce equal sound in both ears, but with presbycusis, the normal ear is where you're going to hear the sound. On the Rene test, air conduction is twice as long as bone conduction in normal hearing, but with presbycusis, air conduction is still going to be longer than bone, it just may not be twice as long. So there is no cure, unfortunately, for age-related hearing loss, so our treatment should be aimed at improving hearing and the quality of life. So treatments include hearing aids, which are the most common, assistive devices like speech-to-text or telephone amplifiers, and then depending on the degree of hearing loss, the patient may learn to read lips or learn sign language. And then for severe hearing loss, we reserve that for cochlear implants. So education is very important for these clients. You want to educate them that hearing loss is permanent, but further loss can be prevented. You want to educate them on avoiding loud noises, or if they're exposed, they want to wear earplugs. Educate them on specific underlying conditions and medications that may play a role and how to manage those. And then you want the patient, encourage the patient to get closer to the talker, not be afraid to ask the talker to speak up or talk slower. Ask the talker to face the patient when in conversation. Patients may be in denial about this and refuse to even wear hearing aids. So it's important to educate them on the importance of treating this hearing loss to avoid symptoms of depression, anxiety, and social withdrawal. And they may need a lot of help from family and friends with coping.